Clinical decision-making under scrutiny, proof, pressure, and gender-affirming care. Personally, professionally, and politically queer is the most honest answer to "what do you do?", a slogan I borrowed from my wife. She insists that I give her credit. The most obvious answer would be clinical psychologist, but that's often followed by the predictable, unimaginative, "can you read my mind?" or unsolicited sad stories. I could say I'm busy with a PhD, but on suicide, that tends to kill the vibe. The Vice Chair of the Professional Association for Transgender Health South Africa, or PATSA, just cues Facebook rumors or the CAS refrain or inappropriate questions about people's genitals. I shit you not. A response? The what? Are they the gay ones who have had the snippy snip? So let's just avoid it completely. Talk about other things I do with my time. Maybe something less controversial and divisive. Something everyone likes. Yes. Let's talk about the dog. Training and agility. Who doesn't like hearing about a dog who stands on her hind legs, who barks on command, weaves between your legs, and has perfect recall, who can close a door, spin in the air, and jump into your arms? Come on, this should be a fun topic. Not only safe, and dog knows how much training I do. Thompson, if it's a girl, why did you give it a boy's name? Oh, for sakes, are you me? Spinning in the air? Really? No. The boy name for the girl dog is what we find the most interesting. Sure, fine. I'll take the opening then. She's named after Rosemary Garland Thompson, I say, hoping the conversation shifts, and maybe it does. Maybe they ask about disability studies, bioethics, or feminist theory. But more often than not, I watch their eyes glaze over and I let it go. Another moment of misfitting, another reminder that most spaces aren't built to hold certain conversations. The word misfits comes from feminist disability studies, particularly the work of Rosemary Garland Thompson. Misfitting describes what happens at the point of contact between bodies and environments. It is relational, it is situational, it changes across time and space. A body does not misfit on its own. Misfitting emerges when an environment does not sustain the shape, function, or presence of that body. What Garland Thompson shows is that misfitting is not primarily about attitudes or intentions. It is about how worlds are organized materially and socially around certain kinds of bodies, while others are required to adapt, explain, perform, or endure friction in order to remain present. Misfitting draws attention to the work that some people have to do to move through ordinary spaces. The effort to stay intelligible, the effort to remain unremarkable, the effort to avoid becoming a problem that needs to be explained. This is not limited to disability. In my research, trans participants described lives shaped by this kind of ongoing negotiation. Misfitting showed up in public space, in families, in institutions, and in everyday interactions. Healthcare did not stand apart from this. It functioned as one of the most consequential sites where misfitting became organized, assessed, and managed. I want to hold on to this idea as we move forward by paying attention to what happens when people encounter systems that demand adjustment from some more than others. What I read earlier comes from the preface of my dissertation. I opened there with something personal, which then moved into questions of self-reflexivity and my position as a trans person, an activist, and a clinical psychologist situated in the very field I was studying. I chose that opening because it reflects a more general experience of living at the margins, where conversations can shift very quickly towards questions of fit, coherence, and acceptability, even when the topic on the table is something else entirely. What becomes interesting, what becomes questionable, and what suddenly requires explanation is rarely neutral. The research itself was a classic grounded theory study which initially focused on suicide risk in the trans community. I began with interviews with trans participants in 2017, exploring how they understood risk, safety, and what made life feel possible or precarious. Those conversations were not limited to healthcare, but access to gender-affirming care and experiences with providers came up repeatedly because they were already shaping survival, exhaustion, and hope. In 2022, I conducted a second set of interviews with healthcare providers about their experiences of providing gender-affirming care in South Africa. That work focused on the practical and relational conditions of care, what it takes to offer support in systems that are under-resourced and unevenly supportive. Most recently, as anti-trans and anti-gender affirming care discourse escalated, I analyzed that material alongside the earlier data. From a grounded theory perspective, this later material sharpened what was already emerging. When care relationships were challenged, certain processes became easier to see. Across this body of work, many concepts and categories developed. I'm not going to try cover all of them today. Instead, I want to follow one analytic thread that runs through trans participants' lives, through healthcare encounters, and through the current moment. That thread is proof. In this context, proof refers to what is required for the next step in gender-affirming healthcare to proceed. It is the information, understanding, and justification that clinicians rely on when deciding whether and how care can move forward. Proof is therefore not a fixed standard. It is shaped by the decision at hand, the risks involved, and the conditions under which that decision is being made. I'm going to start with the trans participants and trace how these demands for proof begin long before anyone reaches a clinic.
I mean, in my own story, what I'm struggling with now is being a new male, right? So, okay, great. I'm a new male. And I had a shit year. I'm dependent on my wife, my family, capitalist, Christian, patriarchal, all trying hard not to judge me. But they are, you know. I'm standing between the other men at Christmas and they're talking about their millions because that's the level I live at. And I'm just like, or they talk about the army around the braai. I didn't go to the army. And there's all that discomfort of not fitting. Well, them. If that's fitting, I don't want it. But, you know, it causes isolation, depression. I don't have money. I can't contribute to my family. I'm male and my gets really big when I've got money. And everyone, I want to feel that too sometimes, you know? And I struggle. I really struggle with that.
Nicholas was a trans man I interviewed early on in the study. When he spoke about masculinity, he wasn't describing a failure to pass or a desire to be recognized as male. He was already being read as a man. What he was describing was something more complicated. Standing among other men in his family, he was legible, recognizably male, but not legitimate within the terms that mattered there. Wealth, military service, a particular form of masculine ease. He occupied the position without being granted the belonging that position promises. This is what I came to describe as legibility without belonging. It's a form of conditional inclusion, being close enough to be assessed, compared, and judged without being close enough to be held or affirmed. What's striking in Nicholas's account is that the discomfort doesn't come from being misread. It comes from being read accurately and still finding that recognition isn't enough. His masculinity is visible, but it's treated as incomplete. His presence is tolerated, but not settled. What becomes clear is that misfitting isn't the opposite of belonging. It's what happens inside belonging when the terms are conditional, when someone is close enough to be held accountable, but not close enough to be held. Nicholas is describing the cost of trying to belong, the isolation, the depression, the exhaustion that come from navigating spaces where recognition is partial and always at risk of being withdrawn. Healthcare often operates through similar logics. Recognition does not necessarily translate into acceptance. Legibility does not guarantee safety, and being seen can increase exposure rather than reduce it. When trans participants talked about being recognized in everyday life, they described it as labor, a sustained effort to be read in ways that reduce interruption, correction, or challenge. This involved managing how one is seen, addressed, questioned, and interpreted by others. Participants described learning how to present themselves in ways that were more likely to be accepted or taken seriously. This included attention to appearance, voice, documents, timing, and context, or learning how much to say, when to explain, and when to remain silent, and weighing up the consequences of being seen. Passing is often spoken about as an endpoint, as though being read as cisgender resolves the problem, but the trans participants described it differently. Being read in a particular way could reduce friction in some situations, but it did not remove the need for ongoing management and monitoring. Recognition remained conditional and could be withdrawn depending on who was looking and what they understood themselves to be seeing. Legibility, then, was not simply about identity. It was about effort directed toward meeting other people's expectations of coherence, stability, and credibility, and that effort was continuous, unevenly required, and it carried a cost. Many trans people arrive in professional spaces already tired. They arrive having done significant work to be readable, acceptable, and believable, often without that work being visible or acknowledged. Under conditions where recognition is conditional and can be withdrawn, participants describe developing distrust as a way of protecting themselves. This distrust was not described as hostility or withdrawal. Instead, it functioned as a strategy shaped by experience and expectation. They talked about learning to be cautious about what they shared, how they shared it, and with whom. Trust was not absent, but it was selective and context-dependent. This form of distrust developed through repeated encounters in which recognition did not lead to safety, support, or fairness. Over time, participants described learning to anticipate misrecognition and to adjust their behavior accordingly. Distrust, in this sense, operated as a way of managing risk. It allowed people to move through everyday situations with fewer negative consequences. It reduced exposure in environments where being fully open had previously led to harm or loss. Understanding distrust in this context shifts how we interpret behavior. What can appear as guardedness, reluctance, or distance often reflects an adaptive relational stance shaped by context rather than individual limitation. When trans people enter healthcare, they often do so without clear knowledge of what will be required of them. They arrive aware that access may depend on how they present, answer, and ask questions. I've heard providers describe these moments using phrases like, "They just didn't appear trans to me," or "I didn't feel that they were dysphoric about their gender." The trans participants were often unsure which narratives would be accepted, which forms of coherence would be expected, and which expressions of doubt or complexity might delay or block access to care. In this context, legibility becomes proof. How someone presents, speaks, and responds is taken up as evidence of suitability, need, or readiness. What had previously been negotiated informally now carries material consequences for their health and well-being. And so, the demand for proof becomes formalized, tied to assessments, documentation, and professional authority. And when assessments inherit normative expectations from the environments they sit in, those expectations quietly reorganize what counts as reliable, reasonable, and ready. This is the point at which providers become implicated, not necessarily as the source of these demands, but as the people asked to interpret, apply, and enforce them. And this raises a central question for practice: how proof is understood, requested, and justified within care relationships. In healthcare, legibility is translated into assessment. Providers become the people asked to decide whether someone's account is credible, sufficient, or ready enough for care to proceed. Most providers did not describe this role as gatekeeping. They described it as responsibility. They spoke about fear of getting it wrong, of being part of decisions with long-term consequences, and of being held accountable within systems that offer little protection for uncertainty. In this context, uncertainty refers to the limits of what can be known at the point of a specific clinical decision, how a person's needs may change, how they will experience an intervention over time, and how future circumstances may shape outcomes. Care proceeds through a series of bounded decisions, each made with partial knowledge rather than through certainty established in advance. Each of those decisions places providers in the position of having to exercise judgment that extends beyond the immediate encounter. Whether or not they saw themselves as experts, they were positioned as such. Many providers were trained to approach gender through diagnosis, criteria, and evaluation. Even when clinicians later move toward affirming frameworks, the residue of that training often remains. The expectation to be sure, to be cautious, to justify decisions can reappear under the language of ethics, due diligence, or care. In practice, proof is assembled through clinical impressions, narrative coherence, affect, and consistency in cross encounters. Hesitation, delay, or deferral often arise at points where providers are being asked to make decisions with limited certainty and high perceived risk, rather than from disbelief in the person seeking care. This is a gap between intent and impact. Providers may experience these practices as careful or protective, while trans people often experience them as being asked to wait, to prove, or to perform legitimacy. Proof shifts location, from explicit gatekeeping to quieter forms of containment that sit inside ordinary care. And this is the tension many providers are holding, staying with clients while managing fear, responsibility, and institutional pressure, and deciding whether to stay or to defer. At the time I spoke to healthcare providers, many were working in settings that offered little consistent support for gender-affirming care. Formal training was uneven, referral pathways depended on location, discipline, or informal networks. Guidelines existed, but were not always visible, reinforced, or institutionally protected. In practice, many providers were making decisions without clear backing. This placed pressure on individual clinicians. They described feeling responsible for decisions that carried undeterminable consequences, while knowing that institutional protection was thin. Confidence was often provisional rather than settled, built through experience, peer consultation, and careful judgment rather than through clear structures. At the same time, trans clients were often arriving already cautious. Past experiences of having to explain themselves, justify their needs, or be delayed meant that trust could not be assumed. Providers were aware of this. Some spoke about feeling the tension of being met with apprehension or guardedness at the very moment when they themselves were still finding their footing. Relationally, this created a fragile starting point. A provider who feels unsure and a client who has learned to be careful enter the encounter together. Early moments take on added significance as credibility and questions of legitimacy begin to carry disproportionate weight, shaping the interaction before trust, shared understanding, or rapport are established. Then the backlash arrived. They entered a field already structured by misfitting. Gender-affirming care sits within environments organized around narrow assumptions about gender, development, risk, and legitimacy. Within those environments, difference triggers resistance, which generates demands for explanation, accommodation, or conformity. This is how misfitting operates structurally. Environments stabilize themselves by placing the burden of adjustment on those who diverge from their norms. Anti-trans actors work inside this structure with precision. They intervene at points where environments already sort bodies, decisions, and knowledge into categories of acceptable and questionable. Through professional language, policy channels, and institutional discourse, they recalibrate what counts as ethical and evidence-based care. The field itself becomes retuned to amplify friction around gender-affirming practice. Clinical uncertainty becomes a site of intervention. Ordinary features of care, judgment, pacing, revision, and follow-up, are recoded as hazards. Decisions acquire symbolic weight beyond their clinical function. Documentation, reasoning, and caution are pulled into service as markers of alignment with dominant norms rather than tools for relational care. This reshapes the conditions of practice. Providers occupy positions that require constant alignment with shifting expectations about expertise and moral authority. Their work unfolds in an environment that continually tests whether care fits prevailing standards of acceptability and gender norms. Trans people encounter that same environment through intensified scrutiny of their accounts, their needs, and their very existence. Misfitting operates here as an organizing force. It structures which forms of care move smoothly and which encounter opposition. It determines where explanation is demanded, where delay accumulates, and where proof begins to multiply. The backlash functions by activating and coordinating these pressures across institutions and public discourse. Within this reorganized environment, care becomes an object that must carry more than its clinical purpose. Decisions begin to anticipate how they will be read, interpreted, and judged beyond the encounter. That shift sets the stage for what follows: proof losing proportion, and care being asked to perform stability in a field organized around normativity and assimilation. In this climate, proof is recalibrated. It is no longer tied only to the decision in front of the clinician and the person in the room. It is stretched across time, audience, and consequence. For trans people, proof becomes a demand to sound credible across imagined futures. Consistency, certainty, and stability are read as indicators that a decision will remain defensible later, even as lives continue to unfold. For providers, proof becomes something a decision must carry beyond the encounter. It has to remain legible to absent readers, withstand reinterpretation, and answer for outcomes that have not yet occurred. Clinical reasoning is asked to travel further than care alone requires. As a result, proof accumulates. What would once have been sufficient for this step now has to secure multiple contingencies at once. Decisions are burdened with work they cannot realistically complete, resolving uncertainty in advance, preempting regret, and insulating practice against future challenge. The effect is a loss of settlement. Proof keeps moving, extending justification outward rather than anchoring it clinically and relationally. This is where proportionality becomes critical, because once proof loses its stopping point, care cannot move without distortion. When I talk about keeping proof proportionate, I distinguish between two different ways proof operates in clinical work: proof for care and proof for theatre. Proof for care is proof that serves the clinical relationship. It is proportionate to the decision at hand. It is oriented towards safety, timing, and follow-up. It is accountable to the person in the room, and it is revisable over time. Its function is to allow care to move forward under uncertainty rather than to resolve uncertainty in advance. In practice, this looks like assessing decision-making capacity for the specific step being considered, documenting clinical reasoning rather than demanding certainty, using uncertainty to plan review and monitoring rather than to stall, and treating responsibility as shared across a pathway, not carried by one person alone. Proof for care accepts that not everything can be known upfront, as with any healthcare intervention and, well, life. Proof for theatre is the kind of proof that is designed to persuade. It focuses on looking credible enough for care to proceed, the choreography of sounding certain, coherent, and convincing. It forgoes authenticity and compounds distrust. Trans people perform legibility, shaping narrative, affect, and presentation in ways they believe will secure access. Identity is flattened. The expansiveness of gender is constrained to cis-normative expectations, and doubt is muted. Non-binary people often contort themselves into binary terms when that feels safer. Legibility becomes labor directed at reassurance. The backlash intensifies this dynamic. Proof is now asked to do additional work, to absorb provider anxiety about reputational risk, future challenge, and moral accusation. Clients sense this pressure and begin performing not only for the clinician, but for the imagined others the clinician must answer to. For providers, proof shifts from supporting decision-making to stabilizing exposure. Clinical reasoning is carried with an awareness that it may be read later by people who do not share the ethical frame of care and who treat trans lives as inherently suspect. Proof for theatre is not necessarily dishonest, it is often strategic. It reflects awareness of expectations, norms, and potential consequences, but it is organized around performance rather than care. In this configuration, proof becomes inflated, future-oriented, and unfinishable. It is pulled toward permanence, certainty, and preemptive justification. Performance expands, assurance accumulates, and care slows. What is at stake here exceeds clinical caution. Proof for theatre becomes tied to legitimacy itself, to whether trans people are allowed to be recognized as knowers of their lives, and whether clinicians are permitted to stand with them without being cast as suspect by association. Anti-trans actors demand proof that is structurally unmeetable. Care is treated as dubious by default. Uncertainty is treated as danger. Regret is reframed as moral indictment. Revision is treated as evidence that the decision should never have been made. That influence operates even when they are not present, because it gets absorbed into the conditions of practice. Clinicians start anticipating hostile interpretation. Documentation starts carrying more weight than relationship. And this collides with something basic about gender and about healthcare. Some aspects of knowing are lived and unfolding. People can know who they are while still needing time and experience to understand what forms of embodiment, social recognition, or medical support fit their lives. Responsible care works with that reality through pacing, review, and adjustment. The backlash treats that reality as illegitimate. It demands certainty in advance, permanence as a prerequisite, and outcomes that can never be revised. When those become the standards, any decision can be reframed as failure, and the safest professional move starts to look like not deciding. When defensibility becomes the primary standard, clinical judgment gets reorganized around anticipated scrutiny. When the safest decision becomes no decision, we're no longer talking about care alone. We're talking about power over who is allowed to decide. What has been unfolding across these slides is a question of power. Power over whose knowledge is trusted, power over which decisions are permitted to move and under what conditions. That power shifts across encounters, institutions, and time. It is shaped by policy gaps, professional vulnerability, public scrutiny, and, yes, the organized backlash. For people providing and seeking gender-affirming care, this produces a specific task: continuing to act ethically and relationally while authority, credibility, and justification remain under review. Across the interviews and subsequent analysis, a consistent pattern became visible. Care continued, but only through ongoing adjustment to these shifting power conditions. This is the process the research came to describe as staying in the work. It refers to the effort required to keep care moving when certainty is unavailable, support is uneven, and decisions may later be reinterpreted by people who were not present and do not carry the consequences. One aspect of staying in the work is keeping proof proportionate to the decision in front of you. This includes keeping legitimacy in the room. Start from the person's self-report as the baseline evidence. Ask for more only when you can name what the additional information is for. Is it for safety, for timing, monitoring, or context? And why is it relevant to this step? Shared decision-making. Make the decision explicit and co-owned. Document what was decided, what was understood, what was uncertain, and what the next review point is. So the proof is the quality of the reasoning, not the performance of certainty. 3. Hold uncertainty without stalling. Use uncertainty to plan follow-up, not to raise the bar. If something needs time, name what time is doing. Stabilizing, gathering a baseline, checking a response, building support, and set a date to revisit. And 4. Sharing responsibility across the pathway. Treat informed consent, monitoring, and adjustments as shared work. The client is not carrying the system's anxieties, and the clinician is not carrying the whole decision alone. Proof stays anchored in a relationship that can respond over time. Work with trans and gender diverse young people, however, carry a particular intensity because uncertainty is unavoidable and because it is so easily misinterpreted. In South Africa, from age 12, decision-making capacity in healthcare is legally presumed. The onus sits with the provider to demonstrate lack of capacity, not with the young person to prove that they have it. Clinically, this means the task is not to establish identity beyond doubt, but to support understanding, reasoning, and voluntariness in relation to a specific decision at a specific moment. Informed consent in youth care is therefore highly individualized. It asks young people to think with adults about their own best interests, a concept that is contextual, relational, and shaped by the supports available to them. Capacity is assessed in relation to the decision at hand, the risks involved, and the safeguards in place. Identity is developmental, relational, deeply personal, and lived. Young people are often approached as future adults in the making, rather than as people with present selves. Care becomes oriented toward who they might be rather than what they are experiencing now. Fear concentrates around future regret, while current well-being is treated as temporary or negotiable. Young people often know who they are, while still needing time and experience to understand how they want to live in the world as that person. Disproportionate demands for certainty are especially distorting in this context. When certainty is treated as the condition for care, young people may feel pressure to present as already resolved. Doubts go unspoken, questions get withheld. Exploration becomes risky because it may be read as instability rather than development. This is where the thread closes back on itself. Providers of gender-affirming care occupy a misfitting position too. By association, we become subject to doubt, scrutiny, and reputational risk. Like Nicholas at the family braai, we may be legible in our role, but not fully legitimate in the spaces that judge us. Our knowledge is questioned, our intentions scrutinized, and our work treated as provisional. This is not accidental. The current backlash does not aim to improve care or refine practice. Its aim is to unsettle the conditions under which care can be offered at all. If trans people are framed as unreliable knowers of themselves, and providers are framed as untrustworthy or ideological, then care becomes permanently contestable. In that climate, proof is never allowed to settle. It keeps moving just out of reach. More certainty is demanded, more justification is required, more hesitation is framed as responsibility. The effect is not better decision-making, but stalled action. What is at stake here is not only access to gender-affirming care. It is whether trans lives are recognized as real enough to warrant care, and whether those of us who provide it are permitted to do so without being treated as suspect. Belonging in care is not earned through perfect legibility. It is created by relationships that can hold uncertainty without turning it into exclusion. Staying in the work means holding our nerve, resisting the drift toward defensive practice, and continuing to offer care that is thoughtful, proportionate, and responsive to the people we are actually accountable to.